So I think we'll probably get started. It's my pleasure to introduce Dr. Phil Carrott for today's Grand Rounds. Dr. Carrott grew up in Kansas City and attended Washington and Lee University here in Virginia. His path to surgery included research in pharmacology and a master's degree in medical genetics from the University of Aberdeen, and then followed by medical school at the University of Kansas. He completed his general surgery residency at Brown University, and then his research fellowship in Virginia Mason in Seattle, before finally coming to UVA for his thoracic surgery training, where I got to know Phil. Following his CT fellowship here at UVA, Dr. Carrott spent 6 years at the University of Michigan, where he really honed his skills in complex thoracic surgery. He then moved to Baylor, St. Luke's, and Houston before returning to us in 2021. Dr. Carrott is the surgical director of the lung transplant program. He's an outstanding clinician, surgeon, and educator. His commitment to teaching was recently recognized by our new award for the Kurt Tribble Teaching Award in Cardiothoracic Surgery. Just so you guys know, if you're not aware, it's where our I6 and senior fellows nominate a CT faculty for training in Dr. Tribble's recognition. And Dr. Carrott was the first one to receive this award, and I'm not surprised. I did fellowship with him, and from just really the get-go, he's always taking students and every learner through operations. He has incredible patience and technical expertise that allows him to do this. We're very fortunate to have him here as a colleague, so please join me in welcoming Dr. Phil Carrott for today's Grand Rounds, Transplantation in the 21st Century, Normothermic Regional Confusion.
Thank you for that kind introduction and for the opportunity to talk today. I don't know how we get the up on. There's somebody with the grab it.
Is it up? You'll be able to drag it from one screen to the other.
Yeah.
You might come back this week.
Oh, that'd be nice. Sounds like you're doing a lot of cases.
Okay, sorry about that. Thank you. So this gave me an opportunity to kind of do a little bit of a deep dive in this newer method of DCD procurement. Over the last kind of 6 years, it's become more common in the United States. The Europeans, like a lot of things, kind of spearheaded this back in kind of the 2010s and have published, kind of early 2020s, late 2010s on it as a routine. And so hopefully we can all learn something from it. I do have some research disclosures, but no personal financial disclosures, and it's not used in this talk. So I'm going to start off with a little bit of definition. So the DCD or DCDD is donation after cardiac determination of death, where the patient has some significant neurologic injury that's not expected to recover, and in kind of trying to allow the organs to be recovered from that person. They're brought to the operating room or a close by critical care venue and allowed to expire. Sometimes they're in the operating room, sometimes they're extubated, sometimes they're not. They're certainly disconnected from the ventilator, but there's variability in timing. I think most places are willing to go to up to 2 hours of waiting for them to expire before calling it off. And this does lead to, obviously, people not expiring. It's about 40% of DCDs are not recovered due to this. There's also a variability in medication administration. Not everybody's even giving heparin before they start. It's hard to circulate the heparin if the heart is not functioning. And then our usual donor is the brain death donor. It's controlled perfusion in the operating room. It's coordinated with various teams recovering the organs. In some countries in the world, euthanasia, patients are allowed to donate, and that's also a controlled donation as it's an assisted suicide. Imminent death donation, I'll touch on briefly, is a DCD patient, but then is perfused as a controlled perfusion without declaration of death. And this gets to be an ethical kind of slippery slope in some ways. That we want to make sure that they're not, a recoverable patient. And this is certainly not done in the United States, but has been talked about in international circles. And then what I'm talking about today, normal regional perfusion, it does have some other different nomenclature, but I think this has become the accepted nomenclature. And then fecal lung perfusion is something that will also be designated as machine perfusion after procurement. So some history of organ donation. The first heart transplant was done in South Africa by this gentleman with rather unfortunate drawing on cover of Time. It was a DCD donor, and interestingly, although he was criticized for kind of, did he kill the patient or whatever, but he did allow the patient to expire before he procured the heart. Subsequent to this, the brain death was kind of more codified in the late 60s, and the first OPO was formed in New England. Before that, the system for allocating organs was just kind of a one-off. You call your local friends that may need a heart or lung, and there was no coordinated, even HLA type matching at that time. In the 80s, the Determination of Death Act was further codified, and then there was a congressional act to form UNOS and the Organ Procurement Transplant Network, and then the Scientific Registry of Transplant Recipients, which is a pretty robust database allowing us to study these patients. In popular culture at the time, I don't know if people remember this film, but I would recommend it. It's directed by Michael Crichton, who, as you may remember, is the Jurassic Park author. He went to medical school at Harvard, and only because he wanted to do creative writing, but was getting C's in creative writing and submitted a essay that Orson Welles had done, and Orson Welles got a B minus. The people at Harvard, so he switched to medicine. Interesting for us. This involves surgical residents uncovering a plot by the chiefs of surgery and anesthesia to make organ donors from folks that expired after anesthesia. Interesting. So around the world, there are varying practices with DCD donation, and while the Europeans are a little bit ahead of us in using these organs more carefully, they do have some of the longest wait times after expiring, after the patient expires. And the center of this is the dead donor rule, which was from a worldwide transplant congress that basically just said we can't kill the patients to procure their organs. And so the donor must be dead to have their organs procured. And so this is kind of a sticking point for NRP, because the theory becomes that if we reanimate the patient, will they suddenly wake up more than they were previously? But Italy has to wait the longest. They still do recover hearts and lungs from those patients. I think they're probably maybe a little bit more impaired than the ones that are only waiting 5 minutes for the no-touch period in between when they expire and when we can start the procurement process. So the ethics, again, so it's beneficence to the patient and non-maleficence to the donor. That in theory, DCDs donors could be harmed by the operation if they're not completely dead because they feel um, the surgical access. But no DCD donor that, in the literature anyway, has regained neurologic function after this 4 to 5 minute wait period. And then just to outline the DCD classification that was at this Maastricht summit. There's patients that in Europe, they've certainly done this more than once. If somebody comes into the ER, is dead, they somehow get them to the operating room and either cannulated or put on ECMO, and then have their organs procured. This is probably an hours long process. The uncontrolled two is somebody that's not, they kind of get somewhat resuscitated, but it's ultimately deemed unsuccessful, like in ER, and the team is mobilized and they're cannulated. That's kind of some of the first people that were the NRP was performed on in Spain back in I think 2009 or so. And then the classic DCGs is control 3, awaiting cardiac arrest. So they're brought to the operating room, and once they die, they're cannulated expeditiously. And then the cardiac arrest while brain dead is kind of some brain dead donors, but then also DCGs that brain dead. So DCG procurements, the history of this is the Pittsburgh group, who was a world leader in transplantation for most of the kind of start of us doing liver and kidney transplantation, came up with a DCD procurement protocol that started a real firestorm among the ethicists, one of which called it an ignoble form of cannibalism, which is probably somebody that may not have a lot of experience with surgery, but they were pretty fiery in their evaluation of it. And it is something that is certainly done quickly. I don't know that it borders on macabre, but the NRP is basically an extension of this protocol. Why is this really important? And this is from NPR. A couple of years ago, somebody did not have the procurement operation performed on them due to some neurologic function in the operating room, and so the physicians, rightly were called off the case. But this sort of thing easily stokes fears of organ donation and are my kidneys going to be removed in a dark alley sort of thing. But it is fortunately very, very uncommon, and I think certainly mistakes happen in a lot of different venues. But these people are usually pretty carefully evaluated by the OPOs and the treating teams. So in the United States, unfortunately for us, we have a lot of donors in general. It's some related to drug use, prevalence, guns and violence. We have about 3 times the rate of motor vehicle injuries as European countries. And this just leads to more donors available. So our use of uncontrolled or extended criteria DCD is not that great. I don't know too many centers that are actively going after people coming into the ER that have not really been evaluated. And the workup could certainly miss things in these sort of uncontrolled settings. But the Europeans, I think in Austria, they transplanted a donor that was, I think, 89 or 90 years old. The ones were put into a much younger person. And it's just the availability of donors is making pushing them to be more aggressive in this kind of shady, or not really shady, but kind of a gray area space of the uncontrolled patients coming into the ER. So in a few European countries, and it's mostly Belgium and the Netherlands, and then in Canada and Spain, they do practice euthanasia. And most of these patients are patients with malignancies, but about 10% or so would be ALS or some brain tumor or something like that. The donor is not going to recover their functional status, and so they opt for assisted suicide. Initially, they did not allow these patients to direct their donation. That is something that we can do in the United States for brain dead donors. And I think probably DCD as well, but it's maybe a little less effective. But if you know somebody that has liver failure or kidney failure, you can have a loved one that is dying. You can direct their organs to maybe be a match for your loved one. And a person I know from Kansas City is a two-time lung transplant patient and an artist. And this artwork is in my living room. It's pretty large, but it's called Ascension, and is kind of pastor background. There's a lot of imagery from Christianity. So you can see the mask and the oxygen tubing. He has a lot of medical kind of imagery, and then influenced by CF, both the mucus and air hunger direct a lot of his work. But he had a transplant about 8 years ago at WashU, and then that proceeded to a sort of accelerated antibody-mediated rejection, and then received a directed donation that was somehow a perfect match, and was retransplanted at Columbia. He's currently living in LA, continuing to make art, and all this is glitter on most of this stuff, which is a pretty messy medium, and so that's sort of interesting. It's an interesting guy. So when does the body and when do the tissues die when patients expire? As I said, that even after 20 minutes or more of circulatory death, we can still recover organs for transplant. Probably not the heart, but maybe liver and kidneys. But while they're not being perfused, the metabolism in the body continues, and the lactate accumulates, and acidosis is likely critical in these organs before they are implanted. It was probably very unpredictable, and only there was some way to reinitiate oxygenation. So, lung transplant after DCD donation, there's basically a limit of the DCD donors are not evaluated well in terms of, can we see their lung tissue? Is it healthy and is it compliant? So EVLP was started to help recover these and evaluate the organs on a perfused system, either the Transmedics or ex vivo perfusing platforms. And that also can help rehabilitate organs in some ways. The staff at these that deal with EVLP now, it was tried as a center-specific thing, but now is more of a regional and a company that will come in and do that for you. In I would say most cases, lungs can be oxygenated directly, but the machine perfusion can help even more to evaluate them. So at NRP, like I said, the Barcelona group led this in the 2000s, published in 2012. They had, I think, 34 liver transplants from uncontrolled DCD donors. And then NYU was the first one to start in the U.S. In 2020. And interestingly, the ethicists at Columbia Presbyterian did not think this was kosher. And so it became a little bit of a normothermic rivalry in New York. That one program was being aggressive and the other was not allowing it. And so this is when the New York Times a few years ago highlighting Dr. Mwazami, and then also NPR picked this up as well about a year later. And I think this is from the end of the article in the New York Times that he kind of calls out the ethicist for theoretical disallowing of this, but if you've ever experienced that, watching a patient die who is waiting for an organ, then you may not have that same belief at the end of the day. So the specifics of it, the nominal NRP kind of takes the thoracic organs out of it, so the femoral vessels are cannulated, and then the thorax may or may not be opened, but the cross clamp is placed on the aorta above the celiac artery. And the standard practice would become to drain the aorta above that, so that there's zero pressure to the brain. And then in TA-NRP, all the organs are perfused in either central or peripheral cannulation. Femoral cannulation may be preferred. The cross clamp is across the aorta in the chest, and then the head vessels are mandated to be drained by our OPTN head, John McGee, who came from Michigan. That this kind of has sort of tempered the ethical concerns, I guess. There's another study out of Europe that they came together and kind of did a Delphi evaluation of this process, and thought that if you're doing TA-NRP, maybe you should have wires or some kind of access before withdrawing support, so you can more quickly recover the heart, as that is a little more sensitive to the acidosis and malperfusion. So they, for whatever reason, did not think it was essential for abdominal NRP, which is kind of an interesting dichotomy. But anyway, so this is the abdominal setup. They use a reservoir, which is like cardiopulmonary bypass, and then it's basically an ECMO setup besides that. And you can see the clamp in the chest here, but the organs are perfused for anywhere from probably 30 minutes to a couple of hours, probably about 60 minutes, 60, 70 minutes median. This is TA-NRP, and you see again the reservoir, central cannulation. One thing that we did one case here at UVA a few months ago, and there also needs to be a clamp on the azygous vein, because that's the main connection of venous return that is not being blocked from the abdominal clamping. And then you can also do femoral vessels, but clamp the head vessels off the aorta. The University of Colorado, they had a consecutive experience of DCDs where they transplanted the lungs after NRP. They did not use UVLP, and perfusion times were 50 to almost 2 hours. And they are advocates for early PA venting. So they have this set up, but then put another cannula in the pulmonary artery to drain to the venous reservoir that takes even more pressure off the lungs. And hopefully still has some perfusion, but is not having over perfusion to the lungs. All patients were extubated post-op day 1. They had one death of the series, but from non-pulmonary source. This is their University of Colorado setup, showing the reservoir, some vacuum to the venous side. So I don't think that this is sort of a cobbled together thing that other facilities may have something more complex, but here's to what it's done. And then this is the flow sheet from our NRP case at UVA, just to show you the things that they're recording, and giving heparin antibiotics, some bicarb, looks like ×3, plasmolite. So they have their flow starting at a certain time. The patient was pronounced with death at 1448, and they were on ECMO half an hour later. Not a bad pH, good PaO2, and pretty high lactate that, while it didn't totally correct, the base excess did correct by the time they finished, about an hour later. And by the time they were done, we had already taken the lungs out. This was a direct procurement for our side and our patients as well. So really one of the main sticking point is the neurostatus, and what we how we evaluate this. this study I thought was pretty interesting that they had a reasonable number of patients, it was about 30 or so, but they used the BIS monitoring, which is the forehead thing the anesthesia uses, pupillary monitoring, and transcranial Doppler, and the BIS activity went to 0 in all people, and the transcranial Doppler did show one patent vessel for each patient, but no flow after NRP was initiated, and the pupils were 0 in all patients. So I think that it was pretty careful and, showing some, safety in terms of, these people aren't going to be feeling this, and they're not going to be alive once they're put on ECMO. So in lung transplant, this had become kind of a hot button subject, and one of the reasons I wanted to, present on this and look into it is that there were very conflicting reports of the lungs being good or not being good after NRP, and so there obviously is varying methods of preservation, whether it's abdominal or thoraco-abdominal, the NRP status, and then whether they're put on machine perfusion with either the acellular or blood perfusion machines. And also is very heavily influenced by results from Vanderbilt, which was a very aggressive center for this early on. The evaluation probably benefits from the first machine perfusion, but in their series, the kind of hearsay was that the lungs got really boggy. They can only use 10% of them after the perfusion, and so the outcomes were kind of put up for question. And was there more PGD? But was it how dissimilar was it from our current practice? So some of the studies. This was one French study that was more uncontrolled DCD. So that these were 100 runs over 6 centers over like 5 years. So they weren't doing them every day. But about 90% were usable to EVLP, and then 84 of those converted to transplant, with a total 76% conversion from the whole group to lung transplant. Their PGD3 rate was not high. Their survival was good. The somewhat crazy thing was the median preservation time was almost 12 hours for all of the procurement, the NRP, the EVLP, and then the transplant. So quite resource intensive process. This is a North American study, just looking at the OPTN data. And so this was very early on and reported some abdominal and thoraco-abdominal NRP runs. And I think this was a Vanderbilt study that about 50% were transplanted, which is lower than the previous study, but still not bad between the groups, and maybe pretty good for DCD donors overall. There were more, like I said, more discards from other studies, and then the initial case series was 1 out of 6 converted to transplant, which we shouldn't use any data like that. This is from Duke, and they've looked at the SRTR database, and mostly focusing on thoraco-abdominal NRP, and if the heart goes, how is the lung recovery from those patients? They showed like 4-fold higher recovery of lungs from a DCD donor if the heart is going, and the TA-NRP and direct procurement had basically equivalent lung recovery. So that's recovery off the after the perfusion or after an abdominal direct procurement. The non-cardiac group had equivalent function afterwards, and then the survival outcomes were actually better with the TRP at 90 days and overall. And one shout out to one of our fellows, Kunal Patel, was on that study. And then the last few slides I have here deal with some heart function after the TA-NRP. And this group from Vanderbilt looked at the association between the asystolic warm ischemia time, so the after withdrawal, how long does it take to get them reperfused and on ECMO. And then the intraoperative oxygen needs, which is this oxygen extraction ratio, which is kind of how much oxygen the patient is using while they're on being perfused. This is the recipient after the heart is in. And so they found that if the asystolic warm ischemia time is longer than 10 minutes and the oxygen extraction ratio is over 20% for 70 minutes, so that's a very high metabolic rate, that led to more PGD and more deaths, 22% in the highest risk group. And these were all NRP procurements. So this doesn't really project. Those are results, and the blue group is the high metabolism oxygen extraction ratio over 20% group, or the blue group is the asystolic warm ischemia time over 10 minutes, and then as you go out, this is time for the oxygen extraction ratio. And so once you get above 70 minutes, that's kind of when the complications really start to rise in those recipients, and they had severe primary graft dysfunction on for their heart transplant. But if the warm ischemia time was low, then they really did pretty well and were not that metabolically in overdrive. And then another study, also in heart transplant, out of Colorado. You can see our colleague Dr. Tiemann on the author list there. So they studied DCD hearts after reperfusion. So they implanted the hearts, had 10 NRP, had normal machine perfusion, and then 10 rapid recovery, so no perfusion afterwards. And PGD occurred in about half these patients. They took samples from the coronary sinus and analyzed these for the various metabolites present in the blood, and showed depletion of TCA cycle and redox metabolites, accumulation of these acylcarnitines and amino acid metabolites. And so this kind of pointed towards impaired mitochondrial function, increased oxidative stress, and then membrane injury of the either mitochondria or cells. And just to show their results, and these are very busy. And the metabolomics is a little bit opaque because this is a score for the total metabolomic profile, and I can't give you any units for these, but they have no PGD and then PGD here, and then that really closely maps with the method of procurement, with the NRP having kind of more PGD, rapid recovery kind of being in the middle, and then the OCS, which is where they're on the machine perfusion of the heart before transplant, really had the best outcomes and the lowest PGD. Which you may remember Joe, who came here about a year or so ago and showed implanting the heart off the OCS machine while it's still beating. Obviously had zero ischemia time with that sort of strategy, but increasing complexity and other things. But at the end of the day, they're table 1, and the survival to discharge was pretty equivalent in all groups, and actually the best in the NRP group, despite probably more PGD, about 70% in that group. So there are, since this started, multiple companies that have started working in this procurement space, bringing the NRP technology to various hospitals. A company called Procure On Demand is one of actually the leaders in the field, and was started by the University of Maryland I6 residents. The CEO is the first I6 resident that was ever graduated from Maryland, and they will bring their technology to wherever they need to go. The cost range for about probably $4,000 or so for the ECMO circuit, so greater than $50,000 for the Transmedics machine perfusion disposables, and then thousands of dollars for the procurement staff. There's about 5 people that are needed for NRP between perfusion, surgeons, and other nursing support staff. So with flights and organ machine perfusion, NRP, recovery of organs could cost six figures for heart or lungs in this setting, but we really don't have another alternative. The other alternative would be like a lung grown in the lab or whatever, which would probably cost much more. So the DC donors actually just this year are surpassing the number of brain death donors, and hopefully this can increase organ recovery per donor as an NRP strategy, particularly for the thoracic organs. And while the transplant economics are driving innovation, the system is becoming more expensive. We're all doing more things to more people to try to expand access. And ironically, the DCD donors are actually less expensive for the organ procurement organizations, as the care is billed to the patient before they are declared dead. Otherwise, the organ procurement organization is on the hook for the care in the hospital, which I don't know if this is at the front of their minds, but that's something that I've heard from other people working in the donation space. With that, take any questions.
Phil, that was an excellent talk. Thanks for giving overview of this rapidly sort of changing field. Also want to congratulate you, the entire lung transplant team for continuing to grow and really just be not a regional but national presence in lung transplant. A lot of new things that are that you described. So my question is, when you're using NRP for procurement, when you decide whether to use machine perfusion, is that routine? Is it add on the costs? Like is it better actually do both?
I think it probably maybe is equivalent. It does add a lot of cost, a lot of time actually. So it's about a 4-hour run to make sure that those organs are functional. And then our experience with the TransMedics machine perfusion is that only about half the time we were able to get the organ to transplant that for whatever reason they would get boggy or edematous. But there's not a great. I think there are a lot of centers that will do it routinely. There's a lot of centers that won't do it routinely. I don't know that we really know what where the sweet spot is in using that technology.
I don't think we've met. I'm Stephanie Silvey. I'm one of the abdominal transplant surgeons. I trained at Baylor with Angie Wall, so we were one of the first groups to do a lot of abdominal NRP. So I have a special love for this topic. So thank you. A little difference on like the abdominal side. I was just going to pipe in. It's really changed liver transplant completely. We're using DCD donors in the last 5 years that we would have never even considered 20 years before that. And Sean probably could have spoken to that. For cannulation techniques, I know you mentioned some femoral cannulation. So we worked with our ECMO surgeons and our cardiac surgeons. They teamed up with us to create our NRP program. And we did do some femoral cannulations, which actually does require consent from the family prior. And our ECMO surgeon did it so that we could be completely removed. And it was really interesting because she always had very positive feedback from the families of saying that they were happy that we had techniques that would maximize the gift of their loved one, which was, I think that was a really interesting part to see with NRP as well. And then we favored abdominal cannulation when there was no heart team involved. We did direct abdominal cannulation into the distal aorta and IVC. And then we did a balloon occlusion of the thoracic aorta because it was the fastest way to do it. And then we would open the chest after we were on bypass and clamp and cut. And then if the heart team wasn't involved, we would just cut the ascending aorta to make sure there was no flow. But yes, special love for this topic. Thank you so much for giving us a background. And Francisco wanted to be here, but he's giving a talk, so sorry.
Sure. Yeah, that was fantastic. To put this in perspective, it's really a major advance in transplantation because the bottom line is that these techniques allow us to use organs that otherwise, in all likelihood, wouldn't be used. And so the real, where the rubber meets the road on these types of things is how to pay for it. Because it's very expensive. And in the way that transplant reimbursement is organized, there needs to be places where you can pass the cost onto. And if you are working with a limited margin for a given organ transplant, whether it be lung, liver, heart, and so forth, if you add another $100,000 onto the cost, it has to go somewhere. And right now, institutions in general are not so well off that they can just absorb that cost.
Yeah.
And so how are you doing in dealing with the cost for lung transplants?
But it's certainly, I think, a volume sort of calculation, but yeah, there's definitely a healthcare policy that probably needs changing in terms of how Medicare is funding all of this, if they will fund all of this. I don't know. Like overall, healthcare is relatively underfunded, for a variety of reasons in the United States. But we should probably look to our European colleagues to see how they're paying for it all, whether it's totally, from the government or what the agreements they've worked out with the various stakeholders.
I think one of the remarkable things about the Vanderbilt program, which grew to be the largest heart and the largest overall transplant program under the umbrella of this type of technology, is that they were able to do so many heart transplants. And I don't have enough contact to know how they're specifically dealing with the cost. But when you think about sort of a long-term costs and how they're dealt with for any procedure, it becomes challenging and problematic. So do we have a limit as to how many of these that we can do, or how do you deal with it on a case-by-case basis?
I don't think we do, to be honest. I think it's probably better to get the transplant done than not overall. And the list has changed over time so much that especially the lower kind of mid-O list is really a desert of opportunity for the patients that are kind of just medium sick and maybe challenged with either height restrictions or other issues. So getting those people transplanted is a challenge, and this is certainly one way to do it. Whether it's kind of directed, or undirected donation or another way to get there.
What's your take on, in cases of TA-NRP with, cardiac donation as well as lung, the venting strategy to avoid lung edema? I mean, I think at ISHLT there was a lot of chitter chatter about whether the left atrial venting is appropriate enough and how much volume you're putting through the lungs. And then also, do you mind commenting on the amount of time necessary to analyze whether you're going to take the heart? They have to reanimate it, they have to sit on and then evaluate, metabolic and hemodynamic parameters, whether you're going to take it. But if you wait too long and you're perfusing the lungs the entire time because that's necessary for the heart, kind of screws over the lung transplant surgeon a little bit.
Yeah, I think the heart is a little more resilient than the lungs are in that situation, but the decision is probably an hour or so, like what we had here. But you should have a pretty good idea beforehand. But I think that it is going to be there's a sweet spot to not having it go too long and having some other organ injury. I think we're probably overblew the morbidity to the heart or the lungs in that strategy, but it's one of those things that are hard to evaluate if we don't really have a way to perfuse and ventilate. So I think if I was to start doing TA-NRPs here, we would probably have a bias towards machine perfusion and a further evaluation, but that's certainly a difficult to decide area.
Thanks, Will. I think that's great, and it's really it's been such an interesting field to watch grow over the past 7 years, and I think that one of the interesting things that you touched on some was you know who is getting the organs now. So we have companies going out to get the organs. It used to be and still is in some centers like ours, are residents going out to get the thoracic organs, and but now that it's an actual career path for folks to go do this, like how do we keep training our own residents and surgeons for that career pathway? And I wonder if you thought about that at all.
I mean, I think the ability for people to get good experience in that is not a lot of runs, but yeah, there should be some continued training, and for sure. I think if you're picturing a career in heart or lung transplantation, part of that mandates that you'd have experience in that procurement strategy space, and basically have experience on both sides of the patients. I don't know that many people want to go into a very kind of high time consuming or a very variable time intensive thing. But certainly it's an option, and these guys from Maryland have made it work for themselves. And
I see a lot of folks now. I mean, the folks who are staffing this are a variety of people, but truly it is on your own schedule. You can either opt in or out. It's locums work for, you go and you do your procedure, and then there's zero follow-up thereafter. So I think it does appeal to some people at different stages of their career.
absolutely.
Well, Phil, thank you so much for this talk. It's great to highlight some of the great work that many of our faculty are doing here. Thank you.